His testosterone level was low. He went on testosterone. He got off all his antidepressants. And he said to me afterwards, he says, it wasn't depression, it was testosterone.
Before we start, a small disclaimer. The Sex Doctors podcast is not a substitute for medical or psychological advice.
Welcome to the Sex Doctors, featuring Dr. Marianne Brandon, clinical psychologist and diplomate in sex therapy, and Dr. Abraham Morgentaler, renowned urologist and expert in sexual medicine and testosterone therapy. Together, they bring you expert insights into sex, intimacy, and relationships. Let's dive in.
Hello, Dr. Brandon.
Hello, Dr. Morgentaler.
You ready for another podcast?
I am, and I think we have a very important topic here, and a topic that kind of drives me crazy as a therapist, which is getting an accurate testosterone level for my patients, because so often people come to me seeking therapy, sex therapy. They have issues that I think relate to potentially having a low testosterone level, so I suggest that they get their level taken. Well, this is a new idea to them because they hadn't really been thinking about it. But I asked for some specific information to get the testosterone level, like a free testosterone, which I hope we talk about today. And they can't get one. Like their doctor doesn't do it, or their lab doesn't do it, or whatever else. And so ultimately their testosterone gets measured and it comes back low normal.
Right.
And
all the time.
Right. All the time.
Right.
All the time. And the doctor's like, well, it's low normal. And then they lose their interest in following through to pursue whether or not they really do have a problem. So, like, we got to talk about, like, how people can do this, how they can get an accurate testosterone level, and even when to get it. I talk to my patients about getting it, like, if their mood is low, if their energy is low, if they're feeling like their vitality is taking a hit. Those are reasons I would think about testosterone. Like, before I suggest they see a psychiatrist for an antidepressant, I want to see what their hormones look like.
Good for you.
Well, thank you.
Your clients are so lucky.
No, I don't know.
So lucky.
Okay, so that. But then if they have sexual issues like, a low libido, if their erections aren't what they want them to be, these kinds of things. So I'm always recommending testosterone, but I'm always getting back that somebody's got a low normal and everything's okay. So, it kind of makes me want to,
Yes, you got to start somewhere and figure out what's going on.
Well, so how do you get an accurate testosterone reading, and when do you go? When should you go?
Yeah, great. So, listen, this is one of the biggest topics, and the other thing that is tough is interpreting what the results mean.
Yes, that's right.
Yeah. So, and it's, if I may, I wouldn't say that whether or not it's an accurate test. It's about, which is the most useful test or tests.
Okay.
Right? So they're all accurate to some extent, but, what is it that we're measuring that makes the difference?
Okay.
Okay?
What is it that we're...
So listen, there's men and women are, as it turns out, actually kind of similar around this in the testing.
Mm-hmm.
Some people might argue, but so first I just got to explain that when we're measuring testosterone, we're looking at how much is in the body, whether somebody has low levels that might explain their symptoms, right?
Yeah.
So you said, like, when should you test? Who should be tested? And usually for a man, the reason to test is they have symptoms that are suggestive of low testosterone. What are those? So they can be sexual.
Mm-hmm.
The classic is low sex drive,
mm-hmm.
but also guys can have trouble with erections.
Mm-hmm.
They can have trouble maintaining their erections.
Mm-hmm.
The orgasm can feel less intense.
Mm-hmm.
They may have more difficulty achieving an orgasm at all. Those are the sexual symptoms. The non-sexual symptoms tend to be things like the guys are tired without it making any sense to them, like they're tired out of proportion to whatever it is that they do. We're all tired. Yeah, like everybody these days is tired all the time.
Yeah.
But this is a kind of fatigue or that doesn't make sense to them. It's just beyond the pale.
And people often think they go to depression, right? And my colleagues always go there, like which I completely support. But let's not go there until we know that there's if there's a hormonal imbalance. That's what needs to be dealt with first.
Yeah.
And then we deal with what's left over after next week. So
I got to tell you, years ago, I had a patient who was mid-60s, I would say, was a psychiatrist. And he'd been self-treating himself with 3 antidepressants. So his testosterone level was low. He went on testosterone. He got off all his antidepressants. And he said to me afterwards, he says, it wasn't depression, it was testosterone. And he says to me, I've been treating other men with what he called, his term was middle-aged male malaise, like this. And he says, I could have to wonder how many of them have low testosterone.
So here's the thing. So what we do in my profession in general, in mental health, is we treat guys with medicine that makes their sexual symptoms worse.
Right. So, right. Absolutely. Antidepressants are awful for sexual function, Yeah. Right. So they start off with that, and God forbid it's not depression.
Right. So they treat a hormonal imbalance with an antidepressant, and they make the sexual situation worse. It's very frustrating.
And just to be clear, so, we hate to say that testosterone is the cause of a major depression. Like if somebody is thinking helpless, hopeless, suicidal, we don't want to treat them or pretend that testosterone is good therapy for them. But
see, this is why we call you a psychourologist, because that's
very kind of you. Very kind of you. Yeah. So, but there is now level 1 evidence, highest quality evidence from multiple randomized controlled trials that testosterone impacts mood.
Yeah.
Clinicians have seen...
Women too. It's not just men we're talking here.
Women too.
Yeah.
But the everybody always, in medicine, they're always saying, well, show me your large randomized controlled trial. And for a long time, we didn't have that, but it was obvious. If you treated men, you saw their mood improve.
Yeah.
One of the very few first patients I ever treated back in the late 1980s, where I was just trying to figure out, does this thing work for anybody?
Mm-hmm.
I said to the guy, what do you notice? And I'd seen him for sexual symptoms, and those got better. But what he said blew me away, and I've heard variations on this forever. He said, Doctor, I now wake up in the morning, I sit on my side of my bed, I swing my legs over, and I am optimistic about my day. I haven't felt that way in years and years, he said. And there's no question that testosterone can help with mood.
Yeah.
Yeah.
So important. I mean, life is challenging. Like we need to be at our best to be able to handle all of that out there. Right.
So in men, just taking to men for a second, who do we treat or who do we even test for? Because we're thinking about treating and we're wondering if testosterone is the issue. Is I talked to you about sexual symptoms. They're sort of like the psychological symptoms of more sadness, more blue, feeling grayed out, like blah, like loss of sense of excitement, optimism, feeling less energetic, less pep, less motivation to do anything. Some people will say that they feel like they're in a brain fog. They just feel a little bit cloudy. They have trouble. I don't want to get into trouble around name finding or word finding, because that's so common as men get older. It's not always a testosterone. But you put some of those symptoms all together and it starts telling a story. And then there's a third category, which is what we call objective signs, things that you can measure, right? So bone density gets decreased with testosterone. Some people are getting their bone density checked. Muscle mass goes down, fat mass goes up, waist circumference goes up. People say, I'm going to the gym, I can't gain in how much weight there's sort of a regular routine that men have when they work out. It's not like men work out, most men, like on a regular schedule for their whole lives for years. It's episodic, right? Especially after New Year's Day, they've got their New Year's resolutions, they go to the gym for a while. And men are used to being able to start off, if they haven't been doing this for a while, with a certain number of, let's say, push-ups or certain weights with, barbells. And they know that if they keep after it, they're going to be able to do more and more over the course of days to weeks. And a lot of the men now are very savvy about this. And because of the weights, we know what the weights are. They can quantify this. And they say, I can't progress the way that I'm used to progressing my whole life.
Right.
And often that's related to testosterone. So that's who it is.
Okay. So now we've got a guy or a woman, and they want to go get their testosterone level measured.
Yeah.
And what happens? They come back with total testosterone in the low normal range.
Yeah.
Total testosterone is not what needs to get measured. Unfortunately, that's what everybody measures, even today.
Yeah. So, and there's still a lot of doctors who think it's the only test, and that's the right test. So a little backup, I think, important for people to understand. So testosterone circulates in our blood, and blood is what gets it delivered, all the chemicals, to whatever cells needed in the body, whether it's in our brain, whether it's in our toes, right? So it's bloodstream that does it. And in the bloodstream, there are 3 forms of testosterone. It's the same molecule, but it's attached to different things. So the biggest portion, about 2/3 of it, is attached to this carrier molecule called sex hormone binding globulin.
SHBG.
Yeah, it's too long to say, so we abbreviate SHBG. And the characteristic of that binding is that it's bound so tightly that if testosterone is attached to an SHBG molecule and is going past a cell that's screaming, hey, I need testosterone, come over here, it can't free itself up because the only way it enters into that cell is by just being testosterone alone. It has to disconnect from that carrier molecule. And that testosterone unattached to anything is the second form, which we call free testosterone. Free doesn't mean you don't have to pay for it. It just means it's unattached, unbound. And then the third way in which it's around is also with a carrier molecule, which is usually the most abundant protein in the blood called albumin. It can attach to other proteins, but mainly albumin. And that characteristic is completely different than SHBG, which is that it comes on and off that protein very easily. And so we consider biologically available testosterone, or sometimes called bioavailable testosterone, the combination of free and the portion attached to out.
Oh, okay. So, but that complicates matters. If you need a level, you have to now get it you have to get your albumin too?
No. So, in Europe, a lot of people use bioavailable testosterone as a test.
Yeah.
In the United States, it's not used that much. Although people do it. And I think that clearly the best test is free testosterone.
Yeah.
Why? Because free testosterone is the actual component that gets into the cell.
Now, wait, do you just think this, or do others think this too? And, are you backed by research, Dr. Morgentaler?
Yes. Yeah, well, thank you. So listen, so this is a little bit of an evolution. So the reason everybody thought total testosterone was the right thing is because that's how it started. Hormones like testosterone are present in such tiny amounts in the body that it wasn't until the 1970s that they figured out how to detect.
Wow.
And they detected them with antibodies. Antibodies, everybody knows a little bit about antibodies because of COVID.
Yeah.
Right? It's these chemicals that are made by the immune system, usually, and go after very specific, not just chemicals, but parts of chemicals. So you can, we won't go into spike proteins and all those other things, but you can use the antibody to detect minute amounts of stuff. And so in the 1970s came the development of what was called radioimmunoassays, RIAs, and all of a sudden using antibodies, often labeled in that time with a little bit of radioactivity, you could actually go after these tiny molecules. Well, they're not tiny molecules, but tiny amounts of molecules like the hormones like testosterone. So the first thing they knew was testosterone.
Oh, well, total.
People weren't sensitive enough. They didn't know enough yet to look at different fractions of testosterone. Now, the part of the problem is that the testosterone that's bound to SHBG isn't useful, but it's measured with total testosterone. And a lot of people...
Useful to the body. It's not useful to the body.
Right. I don't know who it's useful to, but it's not useful to the body.
So why measure? Why did they measure? Because that's all they knew. That's all they knew. Okay.
So there's a lot of what I call lore, L-O-R-E, like old, I don't want to say fairy tales, but there's things that have been passed on from generation to generation in medicine.
Yeah.
And what was passed on was that total testosterone is the right test. And people didn't like the tests that were developed to measure free testosterone.
Why not?
They thought they weren't accurate or reliable. It's simply not true. But the consensus now is what's acceptable to everybody is what's called a calculated free testosterone. It doesn't matter, but it's a calculation where they measure total testosterone and you get your concentration of SHBG and you can just put it into a computer. They're online now. You can just put in your total testosterone and your SHBG, and it spits out what your free testosterone.
Okay, so if somebody gets their total T measured, but they also have their SHBG, they can calculate their free T on their own.
That's right.
But if they're not getting a free T, they're not getting an SHBG, so they can't do it.
Well, that's probably true.
Okay, so tell me, when my client comes back and says to me, well, I asked for a free T. My doctor said, we do total T. It's fine. It's good.
And to get back to one thing, I know you want to get down to the nuts and bolts. I want to say one thing. You asked me a moment ago, do I just think this? Oh, that evidence for it. I didn't have to answer this. So listen, for a long time, a very long time, I was like a solitary voice in the wilderness. Free testosterone, free testosterone. And nobody believed it. I said the tests aren't accurate, you can't use it. This has changed. So there was a study from Europe called the European Male Aging Study. They've published over and over. It's an excellent study, excellent researchers. And what they showed was something very interesting, which is they looked at men who had symptoms, and then out of their group, they had most of them who had low levels of total testosterone and low free testosterone also. Those guys had symptoms. Makes sense. 2/3 of the time, total and free go together. They're both low or they're both normal.
Yeah. Okay.
So those guys all have symptoms. Makes sense.
Yeah.
Then they looked at two situations where the total and the free were conflicting.
Mm-hmm.
One of them was where the total testosterone was normal, but the free was low. And the others where the total was low and the free was normal. And guess what it showed around symptoms is that the symptoms follow free testosterone, not total. So if the guys had a low total, but their free was normal,
they were good.
No symptoms.
No problems. They had enough free testosterone to do the need of the body.
Total was
right.
And free was low. There you go. So symptom. Okay, so answer your question. Yes, there's excellent science now that shows the free testosterone is the way to go.
And so when my client comes back and says, my doctor won't do free, I only got total, what do I say?
So
what I say is, don't give up.
Good. Yeah. Good. So, man, it's so hard. And part of the hard is that most doctors, especially in primary care, they have this reluctance around testosterone.
Right.
It's killing me. I've got two colleagues now, both doctors who, senior doctors, they both clearly have low levels of testosterone. And even though they've had their blood tests measured and it's documented, their doctors don't want to treat them. And these guys are major figures in their fields.
Yeah.
And the doctors don't have a good reason for them. They feel stuck. And it's because these are their doctors. They don't want to...
Okay. So you're saying even in your field where you're working with other physicians and they should know better, you're still getting the same problem with...
Right. So there's multiple levels of the resistance here. But you're right, which is that the first step has to be to get a blood test. And you have to get the right blood test.
You have to get the right blood test. You have to.
And then you have to be able to interpret. So for men and for women, I want to talk about women a little bit separately, even though it's more or less the same story. But so men, if you're going to get your doctor to order a test for you, you have to insist. I say, I need a free testosterone. They say, well, the tests aren't good. Your fallback is, in addition to total testosterone, please also order
SHBG. And then they're going to go, how do you know about SHBG?
Because there's so much information online.
Oh, okay, yeah.
The driver for testosterone therapy in this country does not come from doctors. Until the mid-1990s, there was almost no testosterone used in this country. Everybody was afraid of prostate cancer in particular. But where it came from is in the mid-1980s came the interest in wellness, right?
Oh, so go to an anti-aging doctor. If you strike out with your doctor just won't do it.
That's one approach.
Go to one of the anti-aging folks because they know about free T.
Listen, mainstream medicine I'm a mainstream medicine doctor, right? I'm Harvard trained, Harvard faculty all the way through. I believe in evidence. I believe in science. But mainstream medicine has let down the public around this issue of testosterone therapy. They're ignorant is probably the right word, ignorant of its benefits and unaware about its safety. Everybody's still worried about prostate cancer, heart attacks, none of which have been shown to be true. And they just don't want to go about doing it.
Okay, so if your doctor really refuses to do the free T that you need, you have to recognize that your total T is not a helpful measure, and you've got to find a doctor who will do it. And just staying in sexual medicine, that might increase your odds of getting the right measure, but it doesn't guarantee it. But the anti-aging folks probably will guarantee you get a good measure.
Yeah.
Is that fair?
In most communities, especially larger communities, you're going to be able to find doctors who do this.
Yeah.
Some people look, some the mainstream docs and the sort of the hospital-based folks often look down their nose at those doctors.
Yeah, right.
They're not practicing good medicine,
Right.
shady, fringe medicine. They don't want to be associated with it. But it's a circular story because those kinds of services exist because the more conservative hospital-based medical community has refused to engage in this.
Right.
Despite the evidence being overwhelming about its importance.
That's something. And this all is relevant for men and women.
Yeah.
So ladies, same thing. If your doctor won't give you a free T, you go to an anti-aging doc or someone else who's willing to do this kind of evaluation.
So let me talk to you about levels.
Okay.
Okay, good. So hopefully somebody who's interested in this, by some of the symptoms we talked about, is able to get a blood test.
Yeah.
And I would just say that if the only blood test you can get is a total testosterone, it can be helpful, especially if it's low. Like I say, 2/3 of the time it's going to be in the right direction. But the question is, what's low?
You're right.
So this is the funniest thing. So I train doctors. I do what's called a virtual fellowship. They're all doctors. They're already out in practice. And then they meet me every 2 weeks virtually, on the computer. And they're from all over the world. I've got a group now from Germany. And one of the sessions that we have is we talk about medical doctors put out guidelines. They put out recommendations from experts on how you're supposed to deal with various things. Prostate, when should you get mammograms, all these different things, right? So we look at 4 different sets of guidelines, and none of them agree on what is a low testosterone. The Europeans, Americans, the urologists, the endocrinologists. It's unbelievable.
My God.
And the reason, and the fellows are all dumbfounded. They may have known about one set of guidelines.
Yeah.
Nobody forced them to read all 4 of these.
Right.
And they say, how is it that nobody can agree? And the answer is that nobody agrees because we don't have an absolute threshold. We don't have a single number that distinguishes who can benefit and who doesn't, because you and me and the next guy, we're all different, and how our bodies use testosterone is different, and then how much SHBG we have that binds that testosterone, and therefore how much free T we have is different too. And so some of these folks are just rigid about it, especially the endocrinologists. If you're below a number, and the number is arbitrary, somebody's picked a number, and it's different here than it is in Europe. It's different for the endocrinologist.
You want to believe that your doctors are following guidelines that aren't arbitrary. You just want to believe it.
Yeah.
You just want to think that there's some great study behind this that makes what your doctor believes justified.
Yeah.
But unfortunately, that's not necessarily the case.
Not necessarily the case. And in some areas, things are more clear-cut. In this area with testosterone, what's a low level, it's not. So let me tell you what I use.
Okay.
Yeah. And most of this is based on clinical experience, really. So for a total testosterone, I think anything that's under 350 is for somebody who's got symptoms, is low.
Yeah.
I would treat. For free testosterone, which I believe is much more important, and if your free testosterone is low, your total does not matter one bit. But if you're able to get a free testosterone and it's under 100 picograms per mil, on the lab sheet, it'll usually get abbreviated as PG/ml. Below 100 is low. It sometimes comes with different units, which makes people bonkered.
Right.
And so 100 picograms per mil is the same as less than 10 nanograms per deciliter, NG/DL. If you've got symptoms and you're below those numbers, I believe if I was seeing that patient, I would give them a trial of therapy. And there's no guarantee, right? I would say that on average, somebody with classic symptoms and a low level, but 80% of the time, they're going to see improvement in some area.
And you know what? Can I just add to this that they may not notice the improvement so much as their partner notices.
Again,
Because, and I see this with all kinds of medicines, not just hormones, that when people get to the baseline of their normal, they don't even notice. They just feel okay. Like, it's not like they're feeling great. It's not like all of a sudden, like, you know, lights are flashing and bombs are going off. Like, no, they're just feeling normal. It's their partner that says, wow, you're better. I see you doing better in this and this and this. So before you give up on your hormone therapy, if you think it didn't help, ask your partner if they see something different.
Like, excellent point. And here's the other thing is that testosterone can help in ways that guys may not always be aware of. So, you know, very commonly as a urologist specializing in sexual medicine, what guys came to see me about was erectile dysfunction. Penis isn't getting hard or as hard as it used to or as hard as they like. And testosterone can help with that in some men, but if the problem is vascular, especially in people who have high blood pressure or coronary artery disease or diabetes, testosterone may not be the solution for them. If the blood vessels aren't good to help with the erection, testosterone may not be the answer. And so some of the guys will come back and even in under ideal circumstances doesn't always respond. And so some men come back and, you know, after a few months, I say, how you doing? And how'd you do with the testosterone? They say, it doesn't work. I say, well, tell me what you mean. I say, it doesn't work. I say, is your sex drive better? Yeah. Is your energy better? Yeah. Better mood? Yeah, I think so. Wife notice anything? She says I'm better. Yeah. I say, so when you say it doesn't work, why does it work? Because my penis still won't get.
Oh, okay.
So those people need something else. Maybe Viagra, Cialis. Usually those will help, but sometimes they don't. We've got some other tricks, but that's for another podcast.
Right.
But you're right, it can be subtle. And when people start with testosterone, they don't know what they're looking for. And it can be a month or more before people start to notice they're better. And some of that is what's complicated is the day-to-day, we all have good days and bad days.
Yeah, right. Yeah.
We have times when we feel more upbeat, times when we don't. And so when somebody goes on testosterone and they're having more of their upbeat days, somebody might just think, I'm just having a good day. I'm having a few good days in a row. Like, it doesn't strike them as a light switch. But what's really interesting to me is that most people with testosterone, they'll start and they'll stop at some point. You know, whatever. They're traveling, they didn't get their refill, whatever it is. And when people go back on testosterone, they can sometimes pinpoint to the hour when it hits them. It's like they're an old friend coming back. They recognize it.
Yeah.
So it's funny. We get sensitized to it, but when it's new, you don't know. Let's talk about women for just a moment.
Okay.
All right. So women, we think about testosterone as the male hormone. Not true. Men have it. Women have it. Estrogen, too. It's not just a female hormone. Men have plenty of estrogen as well. But in terms of testosterone, women have less than men, which is part of the reason that men have more muscle, right? Why we're hairier. Our bones are denser. And so on average, women have about 10% of the amount of testosterone, healthy women, about 10% of the amount of testosterone that healthy men have. So if an average testosterone, so I said to you before, you know, anything, if you're below 350, that's low.
Yeah. FDA
uses a range of 300 to 1,000 for men, nanograms per deciliter. That's what they consider normal. Average for men, adult men, is about 500 as a rough number. Women should be around 10% of that, which is about 50. But women have the same interaction with SHBG as they do with the other. And women have a ton of SHBG compared to.
Especially, isn't it true that if a woman's been on birth control pills or on birth control?
Four times the amount.
If she's been on the pill.
Huge amount.
Right.
So what that does, so if you've been on birth control pills, your SHBG may go out, and it can be there for years after you stop taking it.
Yeah.
So remember how total testosterone is influenced by your SHBG. If you have a lot of SHBG that's bound to testosterone, it's not useful for your body, but it's measured in the total testosterone TED.
Right.
It's there, you can measure it.
Right.
But the cells that need it can't see it. Now, there's a debate in women about whether or not you should use blood tests to determine if a woman is a candidate for testosterone, because it's been hard to say what exactly that number is. And at the very low numbers that women are compared with men, there's again this debate or controversy about whether the tests are accurate enough at that very low. So by and large, the treatment for women is not always based on whether they have a low level. It happens, of course, much more frequently in women after menopause, the perimenopause and after menopause, because their ovaries stop producing hormones, right? Not just estradiol, but also testosterone. And the treatment with testosterone, some argue that you don't even need to monitor those levels either. The way you're looking for with women is to just make sure you don't have excess amounts, which in women can lead to getting more hair in places that are unwanted. You can get a huskier voice. Those skin can get a little bit oily. Sometimes that's good for women, especially after menopause. They can have some dry skin. But those are the kinds of things you do. And so you're looking to treat them until they're symptomatically better and without having any of the adverse effects.
All right, fair. Well, I think it's time to wrap up here.
Great. Was
Do you
it?
have any other words of wisdom for...
Yeah, I think this is such an important topic.
Yeah.
Testosterone deficiency is real in men and in women.
Yeah.
Testosterone, whatever you want to call it, therapy or testosterone replacement, it's sometimes called, can make just an enormous difference in people's lives. And even when it isn't a home run, some of the benefits can just be profound.
Yeah.
Yeah. And there's no doubt in my mind that it's good for general health. So
brain, the heart, the skin, all these things. Yeah. Right, because so much more of our bodies use testosterone than just our genitals. That's just
absolutely
factual.
Yeah. One of the things that, there's some evidence that it reduces risks of coronary artery disease, atherosclerosis, and really...
dementia, right?
And dementia. Once you get... If you've had family members with it, you start reaching 40, 50 and older, that's a terrifying thought for people if they might have it. And dementia's clearly been shown to be linked to lower testosterone levels. So I don't think anybody's done the studies yet where they give testosterone to see whether that reduces dementia.
Wouldn't that be fascinating?
But that'll happen before too long, but you'd have to treat a lot of people for a lot of years. Yeah. That's the difficulty with that. But clearly there's a relationship.
Sure.
Testosterone is important for women's health and for men's health.
Right. Well, on that note, Dr. Morgentaler.
Dr. Brand, it's been a pleasure.
My pleasure.
Until the next time, adieu.
Okay, adieu.
Thank you for listening to The Sex Doctors with Dr. Marianne Brandon and Dr. Abraham Morgentaler. Be sure to subscribe, leave a review, and tune in next time for more expert advice on sexual health and relationships.
I believe in miracles. Where you from? You sexy thing, you. I believe in miracles. Since you came